Sorry, this just takes, I guess, a minute here. All right, there we go. So our next speaker is Tomoyoshi Shigematsu, and Tomo graduated from Osaka University Medical School in Japan. He did his residency at the Japanese Red Cross Society in Wakayama Medical Center and Osaka University Hospital. He then worked as an attending in Osaka University Hospital for multiple years before coming to the United States and working with our team as a neuroendovascular fellow with a pediatric focus with Dr. Berenstein. And he's been a clinical instructor and now assistant professor with us since 2018. He's been an exceptional addition to the cerebrovascular team and a mentor for me, even when he was a fellow and I was an attending, teaching me his skills that he knew and had a varied surgical experience from what I've learned. And so I've really appreciated his mentorship and partnership over the years. Today, Tomo is going to be sharing his experience with treatment of vein of Galen, which at this point is one of the most experienced in the world. So thank you, Tomo. Stop sharing.
Thank you, Chris, for kind introduction. Let me start sharing my screen. Is it successful? Do you see my screen?
Perfect.
All right, thank you so much. So again, thank you for kind introduction, Chris. My name is Dr. Tomoyoshi Shigematsu. I'm a neurosurgery trained endovascular surgeon in the Cerebrovascular Center in Sinai. Yeah. So I just wanted to talk about the vein of Galen malformation because I'm showing the typical course of the vein of Galen aneurysmal malformation kit. Usually the red team residents or the PRFs and PAs see us treating this kind of vein of Galen malformation relatively frequently. And those kids, most of those kids are developing normal, stay in PQ for 2 overnights and just stay as a hotel like, and come back in several months. But probably you may not be familiar with this diseases. So I just wanted to present and give some idea what the vein of Galen aneurysmal malformation is and give you some few points to take home. I would be happy if this helps you, like residents in the future. When you guys get the consult about the vein of Galen malformation, if you feel a little bit more comfortable after this presentation, I'll be really happy. Let's start with the prevalences. It is said that vein of Galen aneurysmal malformation is very rare congenital vascular malformation, less than 1% of all the AVMs. But recently in Germany, nationwide study, like 30 vein of Galen malformation born in 2 years in Germany between 2014 and 2015, which counts 1 out of 58,000 still, maybe still rare. But if you calculate it in the US, it's 62 per year in the US born. And it is the most common cerebral arteriovenous malformation detected in the prenatally and accounts for 30% of all pediatric vascular malformations. Kind of a lot, isn't it? And compared to the other diseases, like let's see, like a very famous amino acid disorders, it's a lot more than these very famous amino acid disorders. It's very impressive. The first vein of Galen malformation, I don't think it's the true one, but it's a very famous one, which is Dr. Ziegler published a case report with a bilateral arteriovenous communication to the which draining into aneurysmally dilated vein of Galen. This was 19 1940s. And subsequently, Dr. Baldry treated two similar cases. It's published. After these cases, many authors use the name vein of Galen malformation or vein of Galen aneurysms for different entities. So it took around 40 years before Dr. Raybould found that the ectatic vein in the vein of Galen malformation was, in fact, the median vein of the prosencephalon, which is the embryonic precursor of the vein of Galen itself. So it's not a vein of Galen, but it's a precursor of the vein of Galen. And the shunt exists right there. After this publishment, Dr. Lasjanius and Dr. Berenstein established the concept of this vein of Galen malformation and described in their textbook, Surgical Neuroangiography. Probably you heard about that textbook. And after this concept, a lot of reports about the treatment started to come up. The first early reports before 2000 generally tends to focus on the technical solutions. So they're introducing that the endovascular surgery may improve improve the outcome of the vein of Galen malformation. So, and probably the surgery is not the way to using these babies. Especially in the 80s, they were not able to save this baby, but by introducing the endovascular surgery, they're achieving some success. And after 2000, much more recent reports focus on more clinical outcomes. Now, after getting the strategy of the embolization, you see that the advancement of the endovascular surgery improved a lot of the prognosis of these patients, like close to 80% get the good outcome. But still, neonates treatment in the neonates may be a little difficult. Our team reported 80% of total occlusion rate and almost 90% of the good clinical outcome, not the perfect, but the good clinical outcome. And this was in 2018. This includes only the patient we started treating in our team. So there are more severe cases like coming from the other institute treated previously, and they already have some deficits. But applying our strategy, we see a lot of kids start in developing well after coming to our facility. Talking about the neonates, 10 years ago, our team presented excellent results in the management of the neonates. This is maybe too small, but out of 9 cases, we only had 1 death, and 6 good outcomes. It's much better than the reports I presented in a few slides before. But I looked into a little bit more recent data, and I found that it is still very challenging and difficult. We couldn't save 3 babies out of 11, and we had a relatively high complication, hemorrhagic complication. So, and I'll talk about the neonatal management a little bit later. I like anatomy, so let's talk a little bit about anatomy. I'm going back to this picture from Raven. So this is the picture around between 6 and 11 weeks. And this is the median vein of prosencephalon, which regresses and go away. And this part's gonna be the vein of Galen. okay? And this median vein of Presencephalon collects the venous blood from these choroid plexus. And as you see, this vein exists in the subarachnoid space. If you remember about the AVMs, the AVMs usually locate subpially. It's not subarachnoid, so it's a little bit different animal. And so the vessel supplies the vein of Galen malformation. Because the vein of Galen malformation exists here, you can maybe easily understand that these choroidal vessels supplies the vein of Galen malformation. This is the scheme showing the vein of Galen malformation. Looking from the side, this is the internal carotid, this is the basilar. So this number 5 is the anterior choroidal artery, and this is the number 4. This is the posterior choroidal artery coming off from the PCA. These choroidal arteries mainly supplies, and the one coming from the top, which is the posterior pericallosal artery, it's a branch at the end of the anterior cervical ACAs, which goes to the vein of Galen. So the choroidal arteries supply the vein of Galen. And I told you this is the subarachnoid space. And so which subarachnoid space is here? Which subarachnoid space is here? The vein of Galen usually exists here. The blue circle, maybe this is a velum interpositum cistern. And the green circle here is a quadrigeminal cistern. So now you I think you have an image where the vein of Galen malformation exists. And one more thing I have to let you know is the vein of Galen malformation is considered as the arteriovenous fistula. It's not a malformation, so it doesn't have a nidus. So the artery directly connects to the vein, and there are some small vessels around it, but those are the angiogenesis, I think. And the targets of the treatment itself, we have to close the fistula or the vein. So it's very similar concept to the dural AVF, which Dr. Kellner recently reviewed in the grand rounds, right? And I'll go to the classification of the vein of Galen malformation next. Oops. If you open Micro's Neurosurgery by Dr. Yasujo, you'll see his classification based on the surgical anatomy. I found it recently, and I found it's very interesting. But because the surgical is not a good option at this moment, I'm not going to talk about this. But from the neuroendovascular standpoint, Dr. Lasjani is classified in 2 types. As this, A, choroidal type, and B, the mural type. Okay. So if we go back to this picture again, the median vein of prosencephalon regress from the front, so it goes away, and then only this patch remains. If the fistula happens in this place, it's choroidal, and then later, if the fistula happens here in the back, it's mural. It's kind of that way I understand. The choroidal type of the vein of Galen aneurysmal malformation has multiple high flow fistulas in this network here, and it exists a little bit more anteriorly, like deep in the velum interpositum or the choroidal fissures. And the mural type has a few fistula, not many, directly to this ball, and locate a little bit posteriorly in the quadrigeminal cistern. And we have to think separately about from this vein of Galen aneurysmal dilatation, which is like somewhere like thalamic or anywhere in the AVM drains into the vein of Galen, and then subsequently the vein of Galen enlarged. So this is totally a different animal. You have to think separately. This is example, choroidal type and neurotype. You see a lot of big vessels getting into the malformation, creating the fissure here directly and even from the ACA. It's a little bit located anteriorly, whereas the neurotype has few fistula, and this goes directly to the, almost directly to the ball, dilated part. All the symptoms, I made it very simple. This is not, this is not explaining everything, but I made it very simple. Neonates present with congestive heart failure, and most of them are choroidal type. Infants afterwards, they present with hydrocephalus, microcephaly, and most of them are neurotype. Of course, after treating the choroidal type, they can develop a hydrocephalus lately, even if they're a choroidal type, but I made it very simple. I think this way, it's very easy to understand. Other symptoms like developmental delay are seizures, failure to thrive, blah, blah, blah. So based on these knowledge, what kind of treatment? As we talked before, endovascular treatment is going to be the main part, of course. But the strategy is staged transarterial embolization. So within a certain limit of radiation, contrast, fluid, per one session, we try to close the fistula, not the fistula itself, as many as possible. Enough so that we can reduce the flow and so that we can allow the baby to grow normally. Okay? So we don't want to take too much risks. We don't want to make it worse. So if the access in getting into these small vessels seems to be very difficult, we just stop that session and then let the vessel grow or let the vessel go away by itself. Or if the patient is very symptomatic, we have to take a risk and get into a smaller vessel and close more vessel, more fistulas. But this is a treatment. We need to know other management as well. How about the mom? The baby is still in the belly. So we can manage a little bit during the baby's in the belly, in mom's belly. I think around 20 weeks, the vein of Galen malformation is detectable in fetal ultrasound. Yes, but it only if the procedure is, think about it. It's detectable with a color Doppler. Okay, and after the diagnosis or the detection screening, we can do the fetal MRI, which shows a very beautiful pictures. We can diagnose the vein of Galen malformation like this, and we also can see the brain itself. We sometimes see a significant brain damage already, and we have some, in those cases, unfortunately, we couldn't offer any treatment. And also the ultrasound is very useful to assess the cardiac function. And if the baby already have the cardiac heart failure, we may give the digoxin to the mom. Okay, and there is no evidence yet which if the C-section or is better, vaginal delivery is also totally fine. But to manage the timing, because we have to get ready. I'm going to talk about the management in neonate next, but you have to get ready, and to manage the timing, C-section is preferred, but it's not necessary. So as I told you, we have to get ready when the baby comes out. And it's going to be the huge teamwork. including OBGYN and NICU, Peds, cardiologists, and Peds and neurosurgery. So of course, pediatrician, neuroradiologists, and anesthesiologists, and our neuro-IR as us. We have to get together and then discuss and evaluate. So immediate, the baby needs to be evaluated immediately. Maybe the baby needs intubation, those things. But really, we really need to ask them to get the umbilical access. That's very crucial for the treatment or to get ready for the treatment. Okay, there are 2 UAs with arteries and then 1 UV. And we also ask we have to get echo and MRI to decide the indication of endovascular treatment. If everything is good, the baby doesn't need to undergo the endovascular treatment. But if the baby has a good brain, and if we see the systolic reverse flow in distal aortic arch in the echo, we don't wait. We go for the endovascular surgery because we know that if the baby has this diastolic reverse flow in distal aortic arch, the baby is gonna get worse for sure. And since we have endovascular surgery established, we don't wait. This is how we get we go into the vascular system. Usually we use the transumbilical access and like this. And we do a transarterial NBC embolization and repeat the embolization until the baby gets out of heart failure. Sometimes it takes like 3-4 times for endovascular surgery sessions. It is almost impossible to close whole fistula in one session, and it's very also dangerous. We don't want to close everything at once. We need, because of the fragile premature germinal layer or the perfusion pressure breakthrough, acute cerebral edema or bleeding like subarachnoid hemorrhage, IVH, thalamic, or other ICH can all happen if we close too much. So it's a very sensitive balance of the risk and the effectiveness, right? Just quickly go review. We go very, very close or past the fistula, the fast fistula itself, and then close the fistula. That's our strategy. And this is the glue injection video. We close the fistula like this with the glue. Sometimes we find we see other teams using coils and onyx, like close the fistula with coil and then inject the embolic material, close the fistula again like this, and then use the embolic material just to close the feeders. It's very effective. It is very effective to reduce the flow in the vein of Galen malformation, of course. And that takes the baby out of the heart failure. But insufficient occlusion of the fistula, it doesn't close the fistula itself. It recruits small vessels in the future, slowly, and angiogenesis. And this makes the further treatment in their later age very difficult and higher risk. So just want to let you know that we do not use coils. We think that coils block the hope. Well, once the baby gets out of the heart failure, we let the baby grow. And next is the management of the infant. So during the infancy, we set up a pediatrician or pediatric neurologist follow-up to monitor clinically to make sure the baby meets the milestones, okay? And we also get the head CT 1, 2, 4, and 6 months to monitor hydrocephalus or calcification or any features of melting brain syndrome. We usually have the kid grow like 5-8 months before starting the endovascular treatment stage. If the baby's cardiac condition gets worse, so it's not stable, or we see any hydrocephalus, anything like that, or regression, delay of milestones, those things can alert us, and then we sometimes do the earlier endovascular intervention, of course. And we see if the patient doesn't gain weight, doesn't drink, doesn't not well, doesn't eat well, that means that it's called failure to thrive. That's the way how we know that the patient's cardiac condition is not good. But let's talk about the hydrocephalus a little bit. So it happens anytime, even in the fetus or neonates, it happens, but it's more frequent in infants. But instead of actual obstruction of the aqueduct from the dilated vein of Galen, it is said that the venous hypertension is the cause of the hydrocephalus, so it's usually it's not obstructive hydrocephalus. So the CSF does not get absorbed properly. So urgent embolization should be carried out first, not a VP shunt. The baby may need a VP shunt later, but not to begin with. There is a very high hemorrhagic complication risk. It's close to 50% in our cohort. And recently, endoscopic ETV is also an alternative, a good alternative that we've been doing recently with Dr. Gatan, having a good results. Here I'm presenting a case with obvious hydrocephalus, as you see here. We did just an embolization, no shunt. The vein of Galen starts shrinking, then keep embolizing, and then the size of the ventricle normalize, and the vein of Galen get cured. So this is how we treat the vein of Galen malformation, even if the patient presents with hydrocephalus. So I'll just summarize. So the vein of Galen malformation, actually the vein of Galen malformation is not the official, right? The correct name is a vein of Galen aneurysmal malformation, right? So it is a arteriovenous fistula in the median vein of the presencephalon. It has choroidal type and mural type. And now the strategy is stage transarterial embolization to make the baby grow normally, and targeting the fistula, not just the artery. Targeting the fistula in the treatment is very crucial. And even if you see the hydrocephalus, that needs to be managed with embolization first. Still, about the vein of Galen malformation, there's a lot of place to improve. And like, for instance, if we need to save more babies, neonates, and there may be a different strategy, transvenous embolization, maybe there's a genetic thing, and there is a place that intrauterine prenatal intervention, there'll be a good place. So if you're interested in, if you become interested, or if you're interested in this field, feel free to reach out to Dr. Fifi as a pediatric director here, or me, of course. And we can work together to make these, to save these babies. Okay, thank you. Is there any questions?
Yeah, Tom, I can ask a question. Thanks a lot for that. It's very helpful, and even having done a couple of these during fellowship, still really appreciate the detail that you can provide. But my question is, in your experience over your career so far, what has been the biggest innovation in treatment, the biggest kind of paradigm shift in the past 20 years or so, do you think?
About the vein of treatment of the vein of Galen, right?
Yeah.
Mm-hmm. Well, of course, the introduction of the endovascular surgery is to this baby, and availability to apply this endovascular surgery to this tiny baby is the big success to treat this patient, to these kind of patients. Yes, to do that, it's not just endovascular surgery. It's just NICU management, anesthesia management, and also at the same time, it's more understood that this disease is more well understood at this moment. Okay.
How about umbilical artery? How big an impact has that had?
Umbilical artery? Oh.
How about umbilical artery access that Alex is so fond of?
Yes. So we know that now we understand this disease. We know that this baby needs multiple embolization. So umbilical artery access really helps not just the management in the neonates, but it helps the later treatments to give us an access. Then we really need this umbilical access at the beginning. So we have to obtain the access, umbilical artery access. It's a very, very huge impact in treating this.
And that's relatively recent, isn't it? Or at least making it routine. Joanna, isn't that, you didn't start out doing that, did you?
It was, it came about, but it was probably more than 15 years ago where it became routine. But yeah, when we receive patients, for instance, transferred or for whatever reason we can't get umbilical artery access in the neonate, then there's a very high percentage of patients that go on to occlude the femoral artery, which isn't necessarily, most of the time, is not problematic for limb development, but they develop small collaterals, but it becomes problematic for repeat embolization. So later on, it makes access very difficult if they require repeat embolizations. So yeah, it's been very useful. We push them, especially when they're born here. They're used, the NICU here is very used to getting the access for us.
Yes. For Dr. Berenstein reported in 1998 the first time, and yes, in the first report with the neonates we presented in 2010, was most of them was transfemoral, surprisingly actually, but now we really know that the transumbilical is necessary for management of these patients, and it's making better outcome.
Joanna, did you have any other comments on this otherwise beautiful presentation?
No, it was a great presentation. I think it's true, and we can't emphasize, like, this is one way that Dr. Berenstein and our group have developed in treating. Other places don't have the expertise or think other methods are better, such as transvenous. I don't think Tomo mentioned those, but we've seen that those other methods have higher complication rates, so hemorrhage in the neonate and that sort of thing. So I think even though this is sort of a more fastidious method, it might require multiple treatments. The clinical outcomes speak for themselves. It's in our opinion the best way to do it.
Mm-hmm. It's great. Another world-class program at Sinai. That's great.
Okay, we've reached 9 o'clock. That concludes our grand rounds for today. Have a great day.